Okay, so let's pick up where we left off before with heel pain syndrome, a common complaint, as you guys already know, in the foot and ankle. And we're talking about four possible entities that we need to evaluate. One is a calcaneal stress fracture. One's a plantar fascial injury, which is the most common. Another is a fat pad injury, basically a contusion to the fat pad, and the other is Baxter's neuropathy. So John, a few weeks ago, was talking about uh, kind of walking and biomechanics involved with that. And there is a difference between walking with shoes on and walking or running without shoes on. And remember, our bodies really developed uh, over the millions of years, primarily without having without having shoes on. So our feet really developed in the absence of shoes, more or less. Shoes came as an afterthought much later after development. So, so this was actually looked at in a study, in this case published in 2014, where he looked at running. So here is running, and this is with shoes on. And the important thing here is if you look at the forces involved, you get initially you hit a heel strike. That's the heel strike. Let me go back to this again. So you start out with a heel strike, and then you transfer your weight over to the toes. You push off from the toes. The next foot comes down, and you get the heel strike, and you go through the whole process again. And obviously, in the case of running, if you're going to have heel pain, it generally has something to do with the heel strike. So we'll talk a little bit about the heel strike. And this is what happens if you have shoes on. And we'll see if you do not have shoes on. Here is the same person barefoot running. And notice what happens. So you get here, you don't get actually a heel strike. When you run barefoot, people tend to run with the whole foot planted on the floor, on the ground. In fact, if anything here, if you notice, it's the forefoot that strikes the ground first, and you don't have that severe heel strike that you get with tennis shoes when you have cushions over the heel. So a lot of the pathology that we're talking about is something that's developed in more modern times, where you're dealing with having shoes on, and they change the actual forces that are applied to the foot and ankle. And there was a famous situation that occurred probably now 15 or 20 years ago, but in the days when new fancy running shoes were all the vogue, in the early days of Nike and the other shoes, people made a big deal about new advances in shoes. And at that time, Stanford was one of the top track schools in the country and was always in a national championship hunt. And then one year, a wealthy alumnus from Stanford decided to buy the entire team fancy brand new running shoes. I don't remember the brand, but I wouldn't want to mention it even if I did. And that year, about half the team was unable to compete because of foot pain and ankle pain. So finally, they decided it was the shoes. They threw away the expensive shoes, went back to the cheap shoes, and the next year they were back in the hunt for a national championship. So shoes are important, and as we'll see in a minute, a lot of what people assume in the past have been good for feet are not necessarily good for feet. And when it comes down to it, just remember that our whole body developed in the presence of having no shoes on. So that's really got to be kind of the baseline in determining what's the best footwear. So the bottom line is that when you run with shoes, you develop this severe heel strike, and that can produce a lot of the pathology that we're going to talk about when it comes to heel pain in a minute. Okay.
The whole idea there, John, I think, is to get rid of the heel.
Yeah, when you when you run when you're barefoot, you don't have the heel strike. I guess the heel is still there, but you actually strike your foot on the whole bottom of
The Army,
the heel.
the Army did a study also on their boots.
Yeah,
Took out all the gadgets that they had put in because of this problem.
yeah. So, and then we'll talk about art support shortly. Okay, so let's see. Robert, this is a patient who has heel pain. What do you think of the x-ray? This is the
Let's see.
symptomatic side.
On the X-ray, I don't see a whole lot
Okay,
abnormal.
I agree with you there. So we did MR scans of both sides. This is the symptomatic side. And here we can see the asymptomatic side and the symptomatic side, T1 weighted sagittal images. So what do you see here?
Yeah, on the symptomatic side, it looks like there's some edema and maybe even a stress fracture there.
Yeah.
Yeah.
So this is a calcaneal stress fracture. This happens to be due probably to the traction of the Achilles insertion. So this isn't the typical heel pain that we're going to be talking about. But this is something you also look for, which is the less common stress fracture at the Achilles insertion. Tayson, what do you think of this case?
So the stir images show some edema
Okay, so
involving the
these are low field scanners, T1 on the left, stir on the right, and you're talking about all the edema down here in the calcaneus. And notice that you have these structures, and in many, many people, you have a continuous collagenous band that goes from the insertion of the Achilles tendon into the plantar fascia here. And here we can see that there's a lot of edema in the adjacent soft tissues, especially down here where we're talking about the plantar aspect of the calcaneus. And this is another calcaneal stress fracture. This is a more common location, and this is typically due to impaction injury rather than traction injury like the last one. And so this is one of the more reasonably common causes of heel pain. And again, this is due to that heel strike, which you get with shoes on that you don't get when you run without shoes on, typically.
So we have a stir and T1 and X-ray lateral.
Okay, so this is PD fat sat. This is a sagittal T1, and this is a lateral plain film.
It's PD fat. Okay. So we have edema in
Okay.
like a dorsum of the like a upper
Okay.
dorsum of the calcaneus.
Okay, so this is kind of like the first case we saw before, probably a traction injury at the Achilles insertion. And this was someone who was in their 60s, decided that they needed to lose weight, went out and started walking. And what we can see is that there's a traction osteophyte extending into the distal Achilles tendon from kind of overuse chronically. But here we can see that there's this subtle bone edema due to traction injury on the calcaneus. Good. Okay, Robert.
Right, so we have a 31-year-old with pain after running, and there's pretty extensive edema in that calcaneus with a fracture through the posterior calcaneus.
Right. And so this is a more extensive trabecular injury where you actually have a very irregular, typically subcortical, what typically is called a stress fracture. Though, as you know, I don't think that's a very good terminology. But anyway, this is an area of fractured trabecular bone. You have loss of signal because the trabecular bone is now fractured and overlapping, so you get dephasing of the signal, and therefore you don't get a signal and it's black. That's what's occurring here. And then we can see the bone edema going along the trabecular, in between the trabecular bone on either side. So this is one of the typical running injuries where you get heel pain. and it's kind of an overuse fracture in this situation. MRI is actually very good at showing these. These were kind of a little bit of a dilemma in the past because most of these are X-ray negative, but now we've definitively shown that many of these are stress injuries, and MRI can really differentiate between the different causes. It often can take a while for these to heal, and a lot of people would get disgruntled and concerned about what it was because at 2 or 3 months out, they may still be symptomatic.
I think clinically you can probably pick it up pretty easily.
Yep.
If you see a negative X-ray, you get an MRI and you have your answer. But clinically, these are tender, and I don't know how well their endorphins are quite high in these runners, and so they don't feel as much pain as we would.
Yeah.
I, of course, would probably fall over, but that's
Okay.
a
Taste.
different story.
Yeah, this looks like a comminuted fracture of the calcaneus.
Yeah. And you can see this is a different character to it. This is actually somebody who actually was on a table. The table collapsed and they came straight down on their calcaneus to the ground. And this is a kind of a pylon fracture of the calcaneus. This has very discrete multiple fracture lines comminuted in the typical pattern, and it involves more the mid portion of the calcaneus as well as the dorsal. So this is a different kind of trauma pattern than what we see typically with overuse injuries in runners.
This is a single event rather than multiple events.
Right. Right, Joe. Yep. So now let's talk about the plantar fascia. The plantar fascia, as you all know, is this collagenous longitudinal structure. It attaches to the plantar aspect of the calcaneus. Typically, we talk about 3 bands coming off, which we'll see a little bit later in the MR examinations. Distally, it starts spreading out and then attaches really kind of to the fibrous tissue at the base of the metatarsophalangeal joints distally. It can tear anywhere along here, but by far the most common injuries are approximately here near its origin from the calcaneus, and there it's almost always starts in the middle portion here, which is the thickest portion of its attachment. And that's probably because you have a bigger cross-section area distally, so per strand you have less strain on the plantar fascia distally than at its origin approximately here. Now, if you notice here, this looks like it's kind of an arch. If you think about the old Roman arches, they have their 2 sides are planted into the ground, which firmly establishes, unless you have an earthquake, the location of these 2 locations, and then you have an arch overlying it here. So the stability of an arch like this is very much dependent upon the stability of the anchor points into the ground, which is the 2 sides. And in normal ground, those are very stable. As you can see,
Newborns do not have an arch. They develop the arch as they start to grow. So most newborns do not have an arch, and that's why I always say to the mothers, the baby was born without an arch, and you don't need to create an arch by buying expensive shoes.
great, good. So,
Yeah,
so most babies have flat feet, and that's physiologic. Now, so what you notice here is that the normal arch physiologically, this is kind of should be fixed positions here. If you put pressure on this arch, there's a tendency to then put longitudinal stretch on the plantar fascia, as you would guess. It's like if you had a Roman arch and it wasn't really fixed to the ground, you put weight in the middle of the Roman arch, then the sides would tend to extend, to move out laterally, and the whole thing would collapse. But they don't collapse because the ground firmly establishes a non-moving base of the arch. So here now, and as we'll talk about in a minute, if you overly put something that's pressing up against the plantar fascia, what that's going to do is put increased strain on the plantar fascia. And we know the weak point is that its attachment to the calcaneus. So if you have too much of a arch support, this will end up increasing the stress of the plantar fascia at its origin from the bone, and you can risk tearing the plantar attachment to the calcaneus. So we'll come back to that. So here's what the plantar fascia looks like on an MR examination, as you're all familiar with. Here's a nice normal attachment, nice and black. The type 1 collagen fibers predominate here, and they should be nice and black, and the bone should not have any edema within it. So when you get what's commonly called plantar fasciitis, which I strongly recommend that people not use, even though that's the common term for it, these are actually not inflammatory lesions, even though they have pain. They can occasionally have redness, so the old definition of inflammation may fit, but biochemically, these are not inflammatory lesions. Biochemically, these are tears of the fibers of the collagen fibers. And histologically, that's what they are. Here we can see more of a distal injury, which is less common. It's thickened with increased signal intensity, and this is a fusiform type tear. We've talked about that in other tendons and ligaments and other lectures, and this is the classic appearance of a partial tear, a type 2 tear of a ligamentous or tendinous structure. And this is more distal, and you can see the pain is right where the abnormality is. And this is a marker for where the pain is. So I think it's important to call these plantar fascial tears. If you call it plantar fasciitis, it implies that it's an inflammatory lesion. That implies that it should be treated with anti-inflammatory medications. And as we've talked about before, though things like steroids can decrease the patient's symptoms, steroids also decrease the healing of soft tissue injuries. And there's a risk that you convert what could be an acute injury into a chronic injury, even though if you pump enough steroids into it, you'll get some relief on the part of the patient.
Well, the steroids would be the worst thing to do, but the anti-inflammatories, I don't think that they're all that effective in this, John.
Right. Yeah. So let's see who's next. I don't know.
I think it's
Because nowadays, general surgeons, for instance, they give you anti-inflammatories even though you have a hernia and you want it to heal. So I just recently experienced that in times two months apart.
Right.
But I cannot take anti-inflammatories, so I have to take something else.
Okay.
so it looks like the central cord of the plantar fascia is thickened with a full thickness defect at the proximal origin.
Okay. So this is typically called plantar fasciitis at its origin here. And again, what this really is a tear of the tendon attachment from the bone. Often you'll get a little bit of edema within the calcaneus if it's acute because of the bone injury that occurs with the traction injury. And you can see the thickening here due to chronic tendinosis. And like we've talked about in the shoulder, where every patient who has a tear of the rotator cuff, at least in large studies that have looked at cadavers, they all have severe underlying tendinopathy, degenerative disease. The collagen fibrils are all disorganized and with a lot of microscopic tears. Normal tendons and ligaments don't tear. The bone is the weak point if you have normal tendons, just like in kids. But in most adults, we start developing degenerative changes of these tendons, so we can get tendon injuries. And the same thing with the plantar fascia. With chronic traction injury, you start getting injury to the tendon. Uh, it becomes thickened with increased signal intensity, which leads to weakening of the tendon and eventually a tear if you continue to stress it. Okay.
In average people, according to Campbell's, um, the diagnosis is usually not available. Uh, in athletes, you can tell the injuries and what causes the pain, but in just regular people that walk and don't do anything but sit and walk, etc., they probably don't come in for MRIs. And if they do it, probably normal. Have you seen that, John, or
Well,
is Campbell's wrong?
well, I don't know. We do a lot of MR scans looking for heel pain in adults and in older individuals, and the most common cause are going to be these partial or full thickness tears of the plantar fascia origin. So we see a lot of these in clinical practice.
Okay. 'Cause I had a difficult time buying what Campbell said.
Yeah, so I don't know. Certainly in the clinical practice out here, MR is commonly used to diagnose these plantar fascial injuries. Uh, maybe who wrote the chapter in Campbell's uh, doesn't use MR and just treats
Right.
them clinically and empirically.
Well, I found mistakes, so it's really not the Bible.
Okay.
So there is uh, edema of the presumably like central cord of the plantar fascia,
Okay.
like a little bit removed from the origin.
Okay.
Maybe.
So here we can see a little signal within the origin, but
Mhm.
we see a lot of edema in the surrounding soft tissues
Mhm.
and thickening and irregularity and increased signal intensity within really the entire proximal plantar fascia here.
Mhm.
If we go to the coronal images, we can see that there's increased signal intensity and probably some hemorrhage and edema adjacent to the plantar fascia. And here we can follow that. On the axial images, we can actually see edema going distally here as well. So again, in the past we called this diffuse plantar fasciitis, but again, these are actually tears with hemorrhage in a patient with underlying tendinopathy of the plantar fascia. Okay, Robert?
Okay. Here it looks like there's a lot of thickening and edema of the plantar fascia, some heel pad edema, and some calcaneal insertional edema as well.
Good, yeah. So yeah, here we also have edema within the pads. We can see thickening, increased signal intensity, very common finding that can be seen. This happened to be an acute injury with a contusion of the fat pad.
All right. So a few centimeters distal to the proximal origin of the plantar fascia, we see a full thickness defect right there.
Yeah. So in these more distal tears, especially when they're complete like this, tend to occur, in my experience, more commonly in young athletes who have marked increase in their training and the stress on the plantar fascia, as opposed to older individuals where the injury typically occurs right here at the origin. Though I think even in most younger athletes, the injury occurs more at the origin from the bone. But in some of these athletes, we see more distal tears within the plantar fascia. And here, this is clearly, you can see a nice tear, full thickness, relatively sharp margins, so there's fraying of the distal ends of the tear. We can see that there's some thickening on either side, so this again is not a normal tendon. It's a tear which is occurring in a tendon that's already thickened with tendinopathy.
Well, in tennis, the movements are quite different from just straight running.
That's
So
right. Yeah.
there are steps that they take that are quite abnormal, and so there are areas of the tissue that don't get stressed, and all of a sudden they are stressed and they tear.
Yeah. So I need to go back and change this lecture, obviously. So symptoms of plantar fasciitis, this really should be symptoms of heel pain syndrome. Uh, so you look for plantar fascial tears, jogger's foot, which we talked about last time. We've not gotten to Baxter's neuropathy yet. Fat pad contusion, we just saw a fat pad contusion. And you can also get muscle tears in the foot, which can also produce heel pain. So that's kind of the differential that you need to go through. And these are generally very well evaluated by MR. Here's just more of a chronic thickening and increased signal intensity with the plantar fascia, maybe a little bony reactive change here from traction injury and partial tear at its origin. Okay, let's see.
So we have thickening of the plantar fascia, like few centimeters from the origin.
Okay.
Is it like um, it's a feels like ossicle, no?
Okay, so now on the T1 weighted image, we see fat, we see dark cortex around it. So this is an ossicle within the plantar fascia. So what is that caused by?
Caused by like calcification, like chronic injury again.
Yeah. So as we've talked about before, there are many areas of the body where we can see ossicles develop within tendons and ligaments. The common ones would be the peroneus longus tendon on the lateral side of the foot. We commonly will see it in the ulnar collateral ligament at the elbow, where about 15% of Major League Baseball pitchers will have an ossicle within the ulnar collateral ligament. I've already shown you examples of these where they start out as a partial tear of the tendon or ligament, and then follow-up examinations several years later will show that an ossicle is developed right at the area of the partial tear. So I think that the vast majority of these are due to partial tears, and this is some people will heal partial tears of the tendon or ligament through a process which where they develop an ossicle. Bones love to heal things, soft tissues
Basically,
don't.
it's due to trauma of some kind or another. Maybe I just got a contusion of the area and some bleeding, and all of a sudden the calcium starts to form.
Yeah. Okay. Robert, what do you think of this case?
Here, I don't see the plantar fascia very well. I mean, there's a little bit of hypointense structure near the insertion. There's a small plantar spur, but I would think there's probably a chronic tear of the plantar fascia.
And then here,
Spurs, I'm sorry, spurs do not cause pain.
yeah, yeah. Spurs, yeah, we should talk about spurs here. And I don't see much of a spur. A spur would really come off as a bony prominence here. Spurs of the plantar aspect of the calcaneus are extremely common. They're in almost everyone over the age of 40, at least in the United States. Probably more so in people who wear shoes. If we did a study in Aborigines or people who don't wear shoes, we'd probably find a lot less osteophytes. These osteophytes are due to partial tears of the origin of the plantar fascia. As we've talked about before, the bone loves to heal things. Soft tissues don't heal very well. So the way a ligament or tendon interface with the bone heals is the bone grows into the tendon or ligament. and that's really what produces the osteophyte in that location. Typically seen in people with degenerative disease, usually because of instability of the joint from cartilage loss. John?
Studies have been shown that heel pain in multiple cases is the same in people with or without spurs. There's no difference.
Yeah,
So,
right. And the spur is an attempt of the body to heal the injury. And back when I was a resident, a common procedure, it was thought, like John is alluding to, that the heel spurs cause pain. And a common surgical procedure was to surgically remove the osteophyte, which would commonly lead to chronic insufficient tear or chronic tears of the plantar fascia and more chronic pain syndrome. The only time
podiatrist only, John.
Okay, thanks, John. Yeah. Uh, the one thing, and the vast majority of the plantar osteophytes in this location are not edematous by MR. However, there are a few of them which are edematous by MR, and probably what can occur is you can get an osteophyte in this location, and with running or walking or so forth, increased activity, you can actually contuse it. But I think that's a very rare cause of pain. Generally, the osteophytes are an attempt at the body to heal, and they're not a source of pain. And I haven't seen any removal of osteophytes in this location in many years. So I think that's pretty much, as John is
With Baxter's neuropathy, you may do some surgery to try to relieve the pressure on it, but you have to be awfully careful, and you have to use special eye gear and special instruments to do it.
Yeah,
So
and remember,
tried endoscopic procedures have been tried, but according to Campbell's, they don't recommend that just yet.
yeah, because remember the bone spur is there to heal the partial tear from the plantar fascia, so you're removing a major part of the bone's healing response. So you're going to weaken the origin of the plantar fascia when you do that. So you have to be careful with that.
If you operate on all the spurs, that pain, you'll get very wealthy.
Right. So here we can see we see marked irregularity and thickening of the distal plantar fascia. We don't really see a good plantar fascia here approximately where we should. You can see this low signal intensity that Robert was referring to, fat in here. Go to the axial images, we can see that fat here, which really looks like it may be interrupting the plantar fascia here. So, and then here's what it looks like coronally. Here we can see fat suppression, and there's the fat. So, Robert, let me show you an X-ray and see what you think of the X-ray.
Okay. So it looks like there's a large, almost looks like a dystrophic calcification. So,
Yeah. So what this is actually a big ossicle here.
okay.
This is a cortical rim around it, and you can see.
Is this my patient,
Yes,
John?
so John's going to tell us about his patient.
Yeah, I treated him when he was in his 50s for heel pain, and I injected him with cortisone, and he was fine after that for many years. Then he retired. He bought a farm, and he did a lot of activity. And one day he started having pain again, and so I sent him for an X-ray, and no, I'm sorry, I sent him for an MRI, and one of our ex fellows read the MRI as being basically negative, and then I asked for an X-ray, and this is what we got, and I did inject him with cortisone a couple of times, and he was well.
Okay.
So it did take care of his problem. He never had any pain after that. He lived another 20 years.
Okay, good.
So just because you see calcium doesn't mean that the patient has pain. That's old stuff right there.
Right. That's all
I
chronic disease.
personally vouch for that.
Yep.
All right, so this lateral heel radiograph, there's a small plantar calcaneal spur.
Okay, so this is 6/23/06. Here's a few years later. Persistent pain over these 3 years.
I mean, the spur is still there. I don't know if it's gotten any larger.
Okay, so it looked the same. The X-ray was basically the same. Patient continued to be symptoms, so this was in 2009, so it was decided to remove the spur to try to relieve the person's pain. And this is 3 weeks after the spur was removed.
So complete avulsion of the origin of the plantar
Right.
fascia.
So they removed the origin here, and obviously that spur was the primary anchor for the plantar fascia, which was removed. And then, yeah, so the plantar osteophyte, as John was referring to, is really not the disease. That's the body's attempt to heal the disease. The disease is really the injury to the plantar fascia itself. Okay.
Never ever have I ever removed a spur, nor anybody ever assisted anybody for that either.
No, I have edema at the origin of the
By the way, the patient was much more symptomatic after the surgery than before the surgery.
No doubt about it.
edema at the origin of the plantar fascia.
Okay, so we can see some
Other-
edema along here. Also, there may be some here in the muscle. Right there. Now, this is what muscle is this? Do you know?
Muscle. Okay. No.
It's the origin of the abductor digiti
Abductor
minimi
digiti,
muscle.
okay.
Yeah. And this muscle is innervated by Baxter's nerve. We talked about that. That comes down medially, crosses over the plantar fascia to the lateral side where the adductor digiti minimi muscle is, and innervates the adductor digiti minimi muscle. And this is a patient who has Baxter's neuropathy. And Baxter's neuropathy is classically thought to be due to trauma to Baxter's nerve, where it crosses over the plantar fascia underneath the calcaneus. And John was referring to maybe an indication for removing an osteophyte might be if you get compression of that nerve from the osteophyte to decompress the osteophyte.
They're very tiny.
Mm-hmm. But
one of the things about Baxter's nerve is that it's very tiny and it branches out. And to see them, it's like looking for a hair in that area. And many times you don't use a tourniquet in this surgery, so you have to be extremely sure of yourself to do a Baxter's type of surgery.
okay.
But it's called Baxter's surgical procedure.
Okay. Robert, what do you think of this case?
Here it looks like there's fatty atrophy of the abductor digiti minimi there.
Right. So with injury to the nerve, you can get denervation, fatty atrophy of the adductor digiti minimi. Now, it's generally thought that Baxter's neuropathy is relatively uncommon, but in a study, I think I may have reference to it in one of my slides coming up, that was done a number of years ago looking at adults who had MR examination. It turns out about 7% of adults will have extensive fatty atrophy of the adductor digiti minimi, and it's thought that the classic process of Baxter's neuropathy is not anywhere near that common. So there is kind of a discussion as to what produces isolated fatty atrophy of the adductor digiti minimi. It may well be that it's trauma to Baxter's nerve, and that the vast majority of people with Baxter's neuropathy actually don't develop clinical symptoms and therefore are silent. But it's not clear now, but it's generally felt that just because at one time in the early days of MR, we thought that if you saw isolated fatty atrophy of the adductor digiti minimi, that was basically a diagnosis of Baxter's neuropathy. But then we were overcalling Baxter's neuropathy based upon the clinical symptoms. So now it's a little bit unclear what the appropriate diagnosis of Baxter's neuropathy is, and whether that's really the same thing as fatty atrophy of the adductor digiti or not. So the bottom line is, when I see it, I just describe that there's fatty atrophy, but I don't bring up Baxter's neuropathy unless there are clinical symptoms which suggest it. And here are just the fatty atrophy of the adductor digiti minimi in the sagittal plane.
Plantar fascia is very normal.
Yeah. So, or adductor digiti quinti atrophy. So it may be entrapment of the first branch of the lateral plantar nerve, which is Baxter's nerve. It's seen in about 7% of foot MRIs. Thought to be maybe due to chronic trauma, maybe due to injury to the plantar nerve. But the vast majority of these patients have minimal, or actually the vast majority have no symptoms that can really be attributed to an injury in this location. And this just shows the medial plantar nerve. This is the Baxter's nerve, and as John was saying, there are actually multiple filaments of the Baxter's nerve. It can be compressed here between the abductor hallucis and the quadratus plani, or it's thought mostly it's compressed here between the calcaneus and the plantar fascia, and then you can get atrophy of the adductor digiti quinti muscle. Okay, so who's next?
It's either me or
Okay, go ahead.
all right. 36-year-old male, heel pain after 9-kilometer hike. So it looks like there is edema in the extensor, the flexor digitorum muscle on the left side, more so than the right. And then the plantar fascia, I guess the medial and central cord are mildly thickened.
Okay, there's a central, here's the lateral.
Central and lateral, yeah.
Okay. And then there you can see edema within the muscle. And this was thought to be Baxter's neuropathy due to the trauma from hiking, compression of the nerve and irritation of the nerve. So, calcaneal nerve. So people believe it's associated with heel spurs and plantar fasciitis. Tends to occur in runners, primarily sprinters. You get medial heel tenderness, typically occurs later in the day, and then denervation of the adductor digiti minimi over here. Okay.
The pain is like on a hill.
Okay, so here's a marker showing where the symptoms are.
Yeah, so it's like edema in a fat pad.
Okay, so there we have edema in the fat pad. There we can see on the coronal PD fat set, we can see that same edema within the fat pad. So what's going on here?
That's fat pad syndrome, like
Yeah, right. So this is called heel pad
heel-
syndrome. That's, or I just call this, if it's acute injury symptoms, contusion of the plantar fat pad. And it's a not uncommon cause of heel pain. Here we can see another example of that same area. Now, chronically, what you can get is fibrous replacement of the fat over time, where you get a lot less edema on the edema images. And this is typical of the pressure lesions, which we more commonly see plantar to the first and fifth metatarsal heads of the foot. And that's because of repetitive trauma to the fat. You get replacement of the fat by fibrous tissue. That fibrous tissue has a lot of nerve endings in it and tend to be very sensitive. I'm sure some of you have already had this issue in the foot. It tends to occur a lot in athletes and a lot in older individuals who fat. And then here's just an example of a pressure lesion overlying the plantar. Not a lot of edema on the edema sensitive sequences, replacement of the fat by fibrous tissue on the T1 weighted images, and that's a chronic pressure lesion. So why don't we stop here? Go ahead.
Special shoes.
Uh-huh. Okay. So why don't we stop here and we'll continue to talk about some bone lesions in this area tomorrow. Okay. Now, by the way, let me see. Let me just. Next week, I'll be here on Monday or Tuesday, but then I'll be gone for 10 days. So we'll stop having lecture after Tuesday of next week for a week and a half.
Okay.
Okay. So see everybody tomorrow. Thanks. Bye.
Have a good evening, everybody.
Thanks, John. Same with you.